This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director of Education at the AARC. I welcome you to today's presentation, Pulmonary Rehabilitation Program Management, Enhancing Services and Exploring New Opportunities. Upon completion of this AARC webcast, participants will be able to identify service format alternatives to maximize patient flow and volume, identify indirect activities that impact FTE allocation, and consider RVU or cost standards to improve FTE allocation. I am pleased to welcome Trina Limberg. Trina is the Director for Preventative Pulmonary and Rehabilitation Department at the UC San Diego Health System. She has been awarded Distinguished Service Awards and a Master Credential from the American Association of Cardiovascular and Pulmonary Rehabilitation and Fellowship from the American Association of Respiratory Care. She has contributed to research in pulmonary rehabilitation and provided numerous training sessions for healthcare professionals. I disclose that I am a paid employee of the American Association for Respiratory Care. Trina has no conflicts to disclose. Trina, welcome to the program.
Thank you, Shauna, and I just want to say I'm honored to be asked to share some information with my colleagues today, and I appreciate everyone taking time out of what is always a busy day to join the webcast. I have, let's see if we can, there we go, move to the slides. So along with those objectives that Shauna read to you just a moment ago, these are some of the discussion points that I thought might be useful in looking at staff and competencies and providing some resources to you on that, as well as discussing formatting services and scheduling staff, referrals and payer mix, and considerations for fixed versus flex budgets and some opportunities for expanding services. I have to say that as long as I've been in pulmonary rehab, I think that most of the clinicians that I meet and share information with, everyone comes from a clinical background and very experienced as respiratory therapists, but not necessarily as much experience as managing budgets and being responsible for leading departments. So I think it's really important to take some time out where we don't often get information to talk about how do we actually run our services. So the first place to start is always the people. And if you have great space, but you don't have the right mix of people with the right skill level and competencies, the outcomes in your program or the level of service that you could potentially achieve is going to be dampened. So I have a position that is pretty much a full-time fixed position. I do see patients as well as direct the department, and I think that's really helpful to the department. But we have a team of predominantly respiratory therapists, and if you might be wondering why you see a 50 to 100% flex, is basically because that's how the budget is based. And later on in the presentation, I'll share with you a little bit about my budget, the flex budget, and what that looks like as volume goes up and down. All the positions at UCSD, which is also a collective bargaining union environment, with leaders being the exception, all the employees are hired pretty much at 50% and then flex based on the volume. And all those positions are benefited positions. There was a time that the multidisciplinary approach was much more favorable and easier for us to maintain, but we had an exercise physiologist, a nurse, and we also had a PT. And as those clinicians moved on to different areas in the field, And I opened the application pool for even nursing and respiratory therapists, because we obviously have, and all of us are aware, a significant number of comorbidities in the patients that we treat. I just really wasn't able to find different disciplines that actually really wanted a career in pulmonary rehab and had some respiratory background. So we have opted to go with a full team of respiratory therapists. And we have adjunct faculty, which is Dr. Manassian is a PhD. She's Associate Professor of Psychology at UCSD, and we carry about 10% of her annual salary. She comes in for 4 hours to actually run coping sessions where patients focus on how to implement the new behaviors of exercise and nutrition and all the things that we teach in our curriculum and all our programs. We are fortunate to have Dr. Reese, my medical director. We've worked together for over 30 years and been fortunate to do some research with him as well. And we have Dr. Soler, who's an assistant medical director. This past year, for the first time in my 32 years at UCSD, I've been able to actually get a full-time administrative assistant. And Laura joined us in October. And I will say that with the increasing volumes that we have and the advent of registration and insurance verification, all that being electronic, it's really key to have an administrative assistant. Otherwise, you're taking what portions of your clinical staff that you have and they're spending time doing administrative type things that actually take them away from direct patient care. So this is our team. And I would be remiss if I didn't share this resource with you. And some of you we're all members, obviously, of AARC, but many are not dual members of MAACVPR. And this is a resource that if you're responsible for developing job competencies, or you just want to develop training for your staff, or you're becoming certified, or you're thinking about certifying your program, this is where the competencies really come from. This is a paper that was published in the Journal of Cardiorespiratory Preventative Medicine, and this is put out by the AACVPR, and there are basically core of 13 professional and clinical competencies that encompass everything listed here, from patient assessment to the new one that was added was oxygen assessment management and titration. It's kind of interesting, this was not part of the competencies before, but now it's actually spelled out. The document is actually constructed to be knowledge, skills, and ability. So it's very relatable to the clinical world and actually letting people know what you really need to have. And if you're looking for ideas for training, and you can see it's a multidisciplinary group, there's nurses and physicians and respiratory therapists as well. So I think before, my goal today is really to expand on what you might know about rehab and running the business. I don't profess to know what you should do in your areas. I'm the first to admit that there's tremendous variability in the way rehab is delivered across the country. Many people are in community hospitals. Some on the call are from rural settings. I happen to be in a university setting, which makes it very different. And wherever you are, I'm hoping, if I do my job well today on the call, that there will be some useful information that when you get off the call, you're thinking about how you might implement it. So before I share with you how we're structured, I think it's important to talk about the physical space, because many people that I meet are sharing physical space with another department, such as a cardiac rehab department, which has really limited their access. Often it's 2 days a week, and cardiac rehab has higher volume typically, and in my own opinion, lower acuity of patients in some regards. And pulmonary rehab may not have the access to the exercise equipment or even the space to conduct initial evaluations where you need a private space to meet with patients. So we have about between 11 to 1,200 square foot, and I'm not going to go through all of the equipment, but it does matter as to the size of groups that you can actually work with and how you actually construct your resistance training, if you actually have what type of Do you have chairs that patients can exercise from with weights or bands, or do you have pulleys? Do you have a sort of a wellness center? So we do have the 6-minute walk track within the department, and we do not share the space with anyone, which means basically 5 days a week in this ambulatory care building, which is about a 4-story building that's on the main campus across the street from one of our medical centers, and we are a multi-site facility. We're opening our 3rd hospital next year, and I'm hoping to get space there if we're fortunate. So I wanted to spend a little bit of time talking about the format of services. There are, I think, many ways to deliver pulmonary rehab, and one thing to think about is whether you're going to focus on predominantly group care or individual care or a mixture thereof. There is no absolute format that you have to follow. We do follow the guidelines at UCSD, and I think everyone is aware, the guidelines from ATS, and I have some references later in the slides for you. But the guidelines basically talk about the content that you have to include in pulmonary rehab. And there was a paper that was published by ATS, ERS, that came out in 2006 that also gave kind of an average of 20 exercise sessions. So programs that are longer actually have better outcomes, but keeping in mind that the Medicare and CMS does not cover, per se, a program. They cover services that are individualized and appropriate to each patient, and the patient has to be progressing with those services. So that is still important and require that level of oversight by that clinician. Even though this is not a talk about reimbursement, you do think about those things when you are formatting your services. So in the group care, we start with an initial evaluation. There's the initial visit. Once we do the initial evaluation, which includes a 6-minute walk, these are scheduled for about 60 to 90 minutes. And we do the 6-minute walk during that time as well so that we can gauge all the things that you need to gauge during a 6-minute walk. The balance, not just calculating their speed. If they don't rest, how much do they rest? Do they demonstrate breathing skills, and do they desaturate? All those important elements to the physical assessment, along with your other standards, oxygenation assessment, psychosocial, and nutrition. So it does take time to get through all of that. From there, an individual treatment plan. In the old days, we called it a plan of care. It's basically the same thing, and we devise that, and then we start the first visit as an individual session where we introduce breathing concepts, and we also start exercising patients given their introduction and medication use as well. So then the structured program in group care is 2 times a week for 8 weeks. We also provide those sessions of education for an hour and exercise for the last hour and a half, because everyone knows it takes some transition time, some downtime to get vitals, get everybody on the right oxygen flows, etc. And then at about below 30 days, within that window of requirement, a reassessment or a one-on-one is also occurring. And those elements to the initial evaluation, including the psychosocial and nutrition, etc., needs to be reassessed. That is a CMS requirement, a Medicare requirement. We do it in everybody, doesn't matter what funding. And then also the discharge, where we're doing another 6-minute walk in the one-on-one sessions. And we can do individual care and do that depending on what the patient's needs are as we see the needs are for each individual patient. In addition to the group care that we're providing, we also have individual care. And we're finding, and I'm not at all surprised, that with the expansion of Obamacare and more Medicaid coverage, that we're needing to expand our flexibility for individual care. And I'll come back to that a little bit as well. But for pre- and post-transplant patients, we see them individually. If they need to be seen, we do their evaluations pretty much the same way before transplant and after. There are infectious concerns about patients that are diagnosed with cystic fibrosis, and we are a regional cystic fibrosis center, although we tend to see more patients that are listed for transplant or recovering from transplant. We do small groups of patients in the post-transplant phase and keep them separate from what I would refer to as the general population because of their immunosuppression. There's also patients with special needs because of limited cognition or cognition impairment where you're working with a caregiver. We have a lot of languages and diversity in San Diego, and we definitely need to do individual sessions when there are special language needs, and we're scheduling interpreters with those sessions. And then scheduling restraints. I mean, the fastest growing population of COPD patients is age 45 to 64, and that is also a working group as well. So what I wanted to sort of kind of walk you through is I wanted to give you an idea of what sort of the blocks of format that we have. And I know this is kind of a busy slide, but if you can kind of hang with me on this, and I'm going to give this pointer a go here too. So let's see here. So if you take a look at the first Monday here, I'm going to explain to you that we basically have 3 concurrently running groups, which you can see each group is up to 12 patients. And at the beginning of the year, I do this schedule, and we do about 18 groups a year of these 8-week sessions. So we create this schedule. And on Mondays, we have 9:30 to noon. Most patients do not want to be in early morning traffic, and they don't want to be in late traffic. Most patients would come between 10 and 1 if we could do that, but unfortunately that is not at all possible. So we run groups Monday and Wednesday. We also have in the red you see here is maintenance. We only offer maintenance for a total of 4 hours per week and 2-hour blocks. And we stagger that so that patients, we've got about 20 to 25 patients that are coming to those given blocks Monday and Wednesday. Later on Monday, we have time to schedule individual evaluations and individual sessions of one-on-ones. On Tuesdays, we start the day with a team meeting where we go over who's on first, and we go over progress of the patients and the individual patients as well. It's really not enough time, but it's the time that we have. We also run a group in the morning, 9:30 to 12. They come Tuesday and Thursday, and that again is up to 12 patients. In addition, Tuesday is really kind of a banging busy day because in the afternoon we also have another group to accommodate patients who prefer an afternoon, which is 1 to 3:30, and then those patients are also coming on Friday at 12:30 to 3 o'clock. And then the afternoon here, we'd have a post-transplant group, which strictly depends on when those patients are referred after transplant. Right now we happen to have 2 patients coming, and we just finished graduating 2 patients. So those patients are coming for an hour to an hour and 15 minutes. And we work with the referring physician to be sure of what we can do with those patients as well as if we can put them in a group so they can't have any infectious issues post. On Wednesdays, before we start a group program, we conduct a pre-conference. We sit with the medical director. We have at least 1 physician there where we go over each patient, their diagnosis, their objective information such as PFTs, echoes, CT scans, and their 6-minute walks, and basically everything that we have, and talk about their targets and what our goals are for those patients. And that way all the members of the team are in the know about all the patients in the groups. This averages about 2 times a month. It runs about an hour-and-a-half meeting. Then on alternate weeks, we either have a staff meeting once a month, research or training, and ongoing safety training, and maybe review a paper or 2. On Thursdays, we have group in the morning, post-transplant, and then time for evaluations in the afternoon. And on Friday, it's the same thing. We have the opportunity to do more evaluations and individual sessions, and then, of course, the afternoon has that group. Our latest appointment is about 3:30. And this year we've been so busy, I'm going to share with you some data on our referral patterns and our referrals and sources of referral. But I've had to actually, for the first time in my career here, define what capacity really is. Because there's so much that we do that's indirect before we can actually sit face-to-face and deliver pulmonary rehab. And we have to consider that as well. I've actually come up with the idea, when you look at all these meetings and you take into consideration that staff have lunches and breaks and oxygen inventory as well as prepping for classes and cleaning the equipment. We wipe the hand weights. We keep them in a plastic container, and it goes underneath the chair with ankle weights, and we wipe all that down. It takes a lot of time out of what would be considered to be productive time where you're actually generating revenue. So out of a 40-hour work week, I've looked at it, and I think what most we can expect of productivity is about 32.5. And if we're looking at 4 full-time people, I would probably schedule for 2 evaluations per team member per week on the average of 8, and then I might pitch in and do a couple more. And also maybe 6 sessions per RTs for one-on-one individual sessions. Not 6 patients, but 6 sessions. Just to kind of share with you, and again, I admit I'm not an expert in this. I'm just sharing with you what we can do and what we are doing, and there's always room for improvement. So. The other area that I think is really important to talk about is your referral sources, and they are changing a bit, at least on the West Coast, and the payer mix. We are about 50% Medicare and HMOs, and that includes also Medicare C as well. We have a contract, which we've had for, I lose track of time, it's more than 5 years. We have a contract with a large group HMO where we are paid a case rate, and those patients come approved for the evaluation and the 16 sessions in rehab. And we also call that lab, and we get the pulmonary function tests and work with those physicians. And this large group HMO, I think, is really ahead of everyone in terms of the preventative model that so much of us are now aware of, given this value-added purchasing and the COPD readmission reduction efforts. What we've experienced in the last year with the expanded coverage of healthcare is that in California, and I apologize, I should have changed the slide, we have what's called Medi-Cal HMOs, which is really Medicare to most people on the call. And what's happening is that a number of patients that were sort of in the gap that were not either 65 or older and had not been disabled for 2 years or didn't work, they were sort of falling in the gap on Medicaid, and we would put in these treatment authorization requests with tremendous justification and all the codes to bill for pulmonary rehab, and the only thing that we would get back approved would be the 6-minute walk test, which really isn't rehab, it's a procedure. And so since the Medicaid HMOs have come about, we have increasing patient coverage where these patients that they're often younger and more disabled, and we were not able to do rehab in those patients, so we're getting a lot of those patients. There's also things to consider with that group, which is health literacy, special needs for languages, some difficulty in getting here for transportation, having the resources and the medications as well. And the HMOs, that one thing I wanted to mention about it, I think is important because we're all aware that many of our patients are on fixed incomes, is that I sort of see a trend with patients that are enrolling in the Medicare CA plans of HMO care. They have higher copays. And those patients, I find just anecdotally, a number of those patients are doing what I would call rationing their care, where they have to consider the copay. If it's $50, which in some instances it's higher than what we actually get paid by Medicare on the COPD G0424 code, that the copays are so high when they come twice a week for 8 weeks that the patients will say, well, I really need this and I really want to come, but I can only afford to come for once a week. And also gas is a factor, and the distance that people have to travel. So we are looking at doing sort of boot camp in those folks, which is a lower level of rehab, less than the Cadillac model of the 2 times a week for 8 weeks, or some programs do 3 times a week and 12 weeks, because we just need to get them in and go over the basics and make sure that they also recognize signs and symptoms of exacerbations. We do work with IPA groups, independent physicians associations, and there are some contracting opportunities there as well. And we also work with PPO plans as well. So our referrals are up about 58%, and our fiscal year runs basically, it's July to June, so we're about ready to finish up this year. If you can see, March was the highest referral processing month I've ever seen in my career, which was 80. And we had a tremendous amount of referrals, and a good number of them are coming from the group HMOs. And let's see, the screening on these patients is taking, I think, and I'm now doing a time motion study, is taking anywhere from a third to a half of an FTE, and I now need to prove that because that's coming out of my flex. It's either coming out of my time, which right now I'm doing all the screening, and I'll talk about that a little bit later, but our administrative staff does not do the initial screening or the actual calls to patients because I feel very strongly, I'm very biased that that needs to be a clinically trained person. We need to be sure that we're scheduling patients that are appropriate to be here. So I also wanted to share a little bit with you about projected procedures and FTEs. So I don't know how many of you are actually integrated on the EMR system, and also with something we're integrated in 2013 in October, which is why our volume is a little bit lower than what was budgeted for. What's in the blue columns under procedured volumes was a higher amount, and we actually came in under budget. And part of that I attribute to because when we integrated to the new computer system, the front office, we had a 60% administrative assistant, really couldn't get the hang of it. So it was coming out of our flex, and we were actually doing the aspect of managing the business, which is called Epic Cadence, where we were registering all the patients as well as doing the insurance verification and doing the scheduling and learning that program. And it was quite a process to get through that. And so in 2015, we were still contending with that. And because we came in under budget, they projected a lower volume for us, and we actually exceeded that. And then this year, we far exceeded what was expected, and we're not done with the fiscal year. So I just finished doing my 2016 budget, and they've now actually raised the bar and added at least 10% higher, and that is now at 7,000. So we've actually had the biggest year ever in the history of rehab for us at UCSD. And I am actually budgeted next year for 5.05 FTEs, and that is actually, in my opinion, under budget, and I'll share with you in just a moment about why. In terms of the annualized FTEs, that sometimes hurts us as well because, in my own opinion, because they annualize generally through February, and December, the end of November through December, all those holidays, patients not wanting to start pulmonary rehab until the new year, new insurances, co-pays, all kinds of things that can affect decisions, also the busy season and people not feeling well. But January and February doesn't really help our cause and usually ends up with a lower budget for FTEs based on the procedure and the amount of time those procedures take, which I'll share with you that in a moment. But typically, that's what happens. And this year, we actually fared a little bit better, not just because our volume was higher, but they also annualized through March, which was one of our busiest months. And the only reason that I have this year is I wanted to show you that the B is for budgeted, A is for actual, and then the flex is for what we actually earned. And you can see consistently that whatever we've been budgeted, with the exception of 13, 14, because we did fewer procedures, we're always under budget. And our cost standards are such, which I'll share those in a moment, that we actually flex up. And so we don't work off of a hospital census because we're outpatient clinics. And this is a really important concept because most times when people are reporting pulmonary rehab business up the chain, it can be to people in leadership positions that are not familiar with all of the indirect costs and therefore may allocate FTEs based on the clinic visits, which are really under-resourcing with FTEs, in my own opinion. So there are no relative value units or cost standards that I could point to as a standard for you. And the way I consider a cost standard is defining the amount of time it takes to provide a given service or product. The AMA has that in CPT codes. They build in physician works. Hospitals are actually, I know at UCSD they've sort of changed the compensation for physicians, are looking more at RVUs. But for us, we really don't have a standard to use. So what I share with you in the next couple of slides is really only homegrown at UCSD through what I would call time motion studies, where we actually tracked things, and it also includes the indirect time that it takes for us to do things like set up for the visit and review the records and document and, you know, some of those things, including scheduling. So what we do is we link that time to a given procedure, and the procedures are unique to whatever your charge description master is, which is sort of like your price list. Like if a grocery store offers, you know, 3 kinds of apples, that's what's on the price list, and they have a code for it. In the hospital, we have different codes and different procedures linked to those codes that are part of the billing process. And then we also have our prices associated with those products or services. We do the 6-minute walk test. Everybody knows that it never takes only 6 minutes. There's always a setup. You're changing the flows. You're doing vital signs. And you are also have a lot of work on the back end with these patients when you actually detect untreated hypoxemia related to their exertion, even if they already have it prescribed, which is what our own studies show. Now you have to write that up, follow up with the physician, make a recommendation for a change of equipment, fax your results, and I say fax because most of our patients are external. They are not part of UCSD. They are being referred from the community, along with this, the VA hospital, the Navy hospital, and also this large group HMO system that refers from all over the county. So the question is, how long does it take to perform an initial evaluation? And the reason I choose this to ask that question is because it's where you spend more time, because it is the compass of creating the individual treatment plan. And if you don't do a good assessment, you're not going to develop good goals for the patient. And then when you sit down to do the reassessment, you really have kind of a shaky foundation. So it's really very important not just to meet Medicare criteria, but to actually achieve the outcomes that you really seek in doing good quality pulmonary rehab. So what is important to think about is how much credit does your department get for doing initial evaluations, because this is the feeder for your group and your individual services, and even if you provide maintenance as well. So I wanted to share with you some cost standards to consider flex staffing. And I also wanted to share with you that I have had a really challenging time trying to figure out how our decision support people, if you will, sort of the accounting and bean counting departments at UCSD function, because they asked me to do the cost standards after we create the budget every year. And I cannot change the cost standards to reach a higher level of staffing. So it's kind of a box, if you will. And I think it's intentional without question. The other thing that happens is they have a formula that they do that I can't recreate, which makes staffing and productivity, hitting productivity targets of 85%. I think the hospital prefers 90, but 85 with the amount of time that we need to allocate to indirect tasks to provide good quality care. So what you're looking at on this slide is some of the CPT codes as well as the 6-minute walk, and then these are just different labels. There's the group code for non-COPD, GO239, individual codes, non-COPD, GO237 and GO238, and then below is the COPD codes. And the cost standards is really the amount of time that we get allocated in addition to whatever formula that they're doing, because what I like to do is take a look at the schedule and see, forecast how many evaluations are scheduled, how many individual sessions, which are about an hour, how many 6-minute walks included in, if it's a non-COPD evaluation. And I should explain that this is a commercial evaluation where you see the CPT code on the second line down, which is 94799. That is a code you may not be familiar with. It's an unlisted pulmonary procedure in the CPT code book where some commercial claims recognize it and others don't. The reason I use it is I try to separate out the different types of evaluations that we're doing so I can track those a little bit better. It requires more staff time, and it's also more time in the space as well. So these are the minutes, and that you can see with the 6-minute walk I have listed 35 minutes because there are a lot of things that have to go into doing the 6-minute walk test. So I don't believe it's tried and true. I think it's less than that. But there was a time that the accounting department went to some sort of a ratio where they created everything was the same. And we all know that an evaluation does not take the same amount of time as doing a 6-minute walk test or doing an instruction on an MDI. It does not take the same amount of time as doing an initial evaluation. So if you don't know how you are allocated staffing, it would be important for you to talk with your leaders, or if you are the leader and you are the person who can influence change, I would recommend that you do so. The COPD products, there's only one code from Medicare. It's G0424. And I have listed here 5 different procedures. In my charge master, there's 5 different procedure codes because those visits are different. The evaluation takes much more time. It is a bundled code. That's a 6-minute walk test is included in. The individual, if we treat COPD patients individually, that is different than if they're in a group, which they are here for 2.5 hours. The exercise we bill usually 1 because the first hour is usually an education session or one of those 4 sessions with the psychologist I mentioned earlier. And then we have the reassessment visit where we're doing some review and using motivational interviewing skills and sort of refocusing and tweaking and inspiring the patient to continue to progress. And then, of course, discharge is a review of progress, solidifying the home program, and so it takes a different amount of time as well. And then I have listed here the non-Medicare evaluation, and the 6-minute walk test is a credit of about 150 minutes. So when we do our costs and our budgets, I think it's important for, I never know what the level of people are in attendance, so I certainly don't want to tell you things that you already know, but do you have and do you know and own your own cost center, or do you roll up into the Department of Respiratory Care or to the Department of Rehab Services or Cardiac Rehab? It's really important to know. We are our own cost center, which means all of our expenses, including depreciation of equipment, all of the benefits for staff, it's salary plus benefits, all of our expenses from the phones to the copier to our office supplies to our oxygen, absolutely everything is visible, and it is not sort of tucked away in a larger cost center, if you will. It's important to know if you're in another department and to be able to work with those leaders and try to understand your budget a little bit better. And I see some people are logging in and they're wanting to know if we're based in a physician's office. We are based at a university medical center, so we are not based in a physician's office. We are an outpatient pulmonary rehab service on the campus of a university hospital. So it's also important to know if your budget is based on a fixed cost center or a flexible one. We are a flex budget, which means if our volume goes up, the staffing goes up. We earn that through our cost standards or RVUs per se. Also, if, say for example, in December our volume drops, we basically, everybody's on vacation, during the holiday because of Christmas to New Year's, because every time we try to schedule visits, the patients generally don't come. So it doesn't make sense to have 2 staff members, which is our standard. No one can be here by themselves. We have to have two therapists. That's in our scope of service. To be here and only have 2 or 3 patients show up. So we definitely look at that. So I basically lead with an abundance mentality, which is we want to flex up, and we always want to grow the services, improve the quality, and provide more services in the community, because we all know and recognize that pulmonary rehab services are considerably underutilized. So it's also important for you to know, as a leader or supervisor in your department, what's your metric for adding staff? Is it your procedure count? Is it your clinic visit? Is it both of those things? Is it your reimbursables? Is it your billables? So it's very important to take a look at those things as well. So again, this is kind of a busy slide, but I like to try to give you a little bit of numbers. I don't know how many of you actually get to see your numbers, but you can see where our units of services that are budgeted from 2013 up to 2015, and now we're going to be at going to be at 7,000 in 2016, and what we actually did. So in most instances, our procedures exceed what was budgeted. In addition, the original budget on FTE, as I mentioned earlier, if you look across that line, it's usually lower. And then the flex budget, we increased to where you can see here we're almost at 5. There were some months that we earned 5 FTEs, like in March, because we were super busy as well. And when you can't figure out the metric that your business office is using to allocate your staffing, it makes it pretty tricky. Even with the experience that I have, it's like you're always sort of chasing that productivity and making sure that you have the right amount of staff on and not too many. And at the same time, I have a team that they're just great people and they're fabulous clinicians, and they all have a really high work ethic. And to keep cohesiveness in your team and everybody growing in their skills and really working well together, I don't want to send people home. And I feel very responsible for keeping my team together and for providing the professional development that they all seek. You can see here, I'm not going to go over all the labor expenses, but clearly our labor is going up. As I mentioned briefly earlier, we are in a union environment, and the staff also have a clinical ladder when they increase their skills and certification, like COPD coordination, an educator, a chronic disease educator, and they work in the COPD clinics. Last year we had actually into this year, the ALS clinic, and we have one particular therapist that we were finally able to convert from a per diem to a career position, which was important and provided benefits for she and her family. So those are things all moving in the right direction. So this is, I think, really important. Where does all the time go? I talk to a lot of terrific therapists when I attend all these meetings that I get to go to, and everybody is working with like 1 FTE and maybe a half of FTE, and they're trying to pull everything together. They're not taking time off when they need time off. And I think a lot of times it's because their leadership may not realize how much time is spent on processing referrals, doing the clinical screening. As I told you before, with our volume, I really feel that we need a half of an FTE to be able to do this. And you all know that when you call patients, you don't necessarily get them the first time, or you schedule the appointment, they don't always come to that. So you have to reschedule it. And you've got some patients, I had a patient scheduled to start rehab on Monday in the group program, and they finally scheduled her cataract surgery, so now I have to defer her and reschedule her. So we do a lot of administrative stuff, and a lot of times leadership is unaware of it. Scheduling and rescheduling, provider calls and faxes, depending on, people within UCSD are easier for us to communicate with, but I mentioned earlier that we're a community resource, and the predominance of our referrals come from outside, which means there is no connectivity electronically, and we have to fax and call and follow up. And you all know that these, particularly when I mentioned earlier these Medicaid HMO plans, they've just been absolutely slammed with enrollment, and so you can send over authorizations to and not get, or rather requests for authorizations and not get them, and have to follow it through a couple of times, and you've got to keep that on your radar. And documentation, we have a lot of documentation, everyone knows, takes so much time, and it really has to be individualized. And billing, you have to enter your charges in a timely fashion, and you need to also be making sure that they're going in correct and that they're coded correctly. I do all of that myself. I have a lead therapist that actually does it when I'm gone, because to me that is the backbone of the business, because that is how they know what procedures we're doing so that we can earn the appropriate amount of FTEs. Meetings and training, and the reason I put this little picture of secretary is because I can't even fathom how many of our trained and specialized clinicians, whether you're respiratory therapists or other disciplines, are actually spending their clinical time putting letters together and scheduling patients and getting all their copies for their presentations to patients and education and all these things together. So if you can get and borrow some administrative time from someone else, that frees you up to see more patients, generate more procedures, and keep your wait list down. Right now, we're screening evaluations out to the 3rd week in July, and we have 2 programs starting in July, one starting on Monday. All of them have 12 patients slated, and we're full, and our referral patterns continue to be really healthy. So some of those indirect tasks are, obtaining insurance authorizations, which can be really time-consuming, managing your oxygen supplies. We all know that, JACO's really been looking at separating full and empty and not having more than 12 E-size cylinders given 3,000 square feet. So you really have to be on it and doing inventory. I mean, we have some patients that are pre-transplant that are interstitial, that are high flow on a non-rebreather at 25 liters, and they'll blow through 2 tanks while they're here. So you really have to make sure that you're on top of your supplies and setting up for your visits and cleaning your equipment. And then customer service is really important. The last impression you want to leave patients with is that you gave them a wonderful experience and that they are truly better and feel better and are more knowledgeable and less anxious. But then they get the bill, and maybe the bill isn't right, and I've faxed one over today or scanned one in and sent it because it doesn't look right, and I tell the patients I will look at all of those. So there is time spent on customer service, parking issues, referrals to other services, and DME issues. You guys know what's going on with oxygen and competitive bidding, and a lot of the patients are not always happy with how things are handled. So it's important to also consider that you have changes in your staffing. Somebody's always out on jury duty. There's unexpected family leaves, and that is also why our volume this year, we had an unexpected leave from one of our clinicians, a strong clinician, who was out for 2.5 months. And so for me, I ended up flexing into the clinic, because you all know you can't just pull somebody, even a respiratory therapist that's practicing in acute care, because they don't have the skill set. They don't know how to exercise patients. They don't know how to evaluate patients unless you've done that cross-training. If you have joint visits this afternoon, I have to go to a regulatory meeting. We have to do a survey to be sure we're compliant with everything. And those are ongoing things. Added training, we do huddles for safety. You have to have safety training every month. We do huddles every week because we're a licensed clinic. And when you have changes within your own healthcare system on upgrades for information systems, and all of those things can change as well. And we need a certain amount of time to review our policies, our processes, and those of you that are thinking about certification, you can go on the AACVPR.org website. You can download the application and just see what it takes to do it. Most people, it takes a year to do it. If you're just starting a program, I would suggest that you hold off and work on your processes and your policies and procedures and and getting your business in order first. So some thoughts on budgeting is in terms of FTEs, your salaries and your benefits, we also carry about, I think it's between $25,000 and $30,000 a year on our budget, which is for administrative services for physicians. And there are three, our medical director, a supervising physician, as well as the psychologist. We carry 10% of her annual salary as an adjunct faculty for us. She also does in-services on assessing for patients who are depressed, suicidal risk, motivational interviewing, how to work with patients that have anxiety. So she also contributes to our training, as do our physicians. Medical supplies, oxygen, we spend about $5,000 or more a year on. We don't have rentals. We just have a contract with a company that we sort of piggyback off of respiratory care. We have e-cylinders. We have walkabouts that we don't have to change the regulators because that helps with high flow patients. Oxygen sensors, we have some Massimo oximeters, and some of the probes, even with good discounts, are $150 for forehead, $125. So these things have to be built into your budget. And also capital equipment, I put in every year. I keep track of my treadmills. They do break down, they do age, and you do need to get them replaced. And we have 4 new steps, and we could probably use another one. We also have a SiFit and a upper body cycle ergometer. There's also non-medical supplies, office supplies, which are going up, the telephone services, copiers, education materials, all those things that add up. I wanted to say a little bit about EMR integration. I did mention this, and I just have it on the slide for you. Collecting copays is also something that takes administrative oversight. You have to have a check and a balance when you're collecting money in cash, and even debit carding and credit cards in your clinic. That usually falls to the leadership. And also with EMR, the ITPs, one of the biggest problems is that they are not individualized enough. Those of you that are members of AACVPR may have seen that there was an email that came out this week that they audited the ITPs that were submitted, and they found like 30% did not meet criteria. So expanding services just a little bit, and there are those of you hopefully will be able to just go back and access the slides so that you can get a couple of the references that might be helpful to you. But the COPD readmission reduction, I have a very strong bias and opinion that I think professionals in pulmonary rehab, we are the only people that treat these patients in a chronic state day in and day out. So I think partnering is really very, very important with the acute care respiratory therapist and investing in education with them. We consider ourselves to be ambassadors of chronic care, and we want to expand that to patients that have interstitial chronic diseases as well, based on this model that we've created. We also service these patients after readmission in the outpatient clinic, and a lot of them are either known to us in rehab or need to be referred to rehab, so we partner with our pulmonologist as well. Allows us to solidify education and keep them tied in over time. Some hospitals have ACOs, we do not. Disease management is on the forefront. I think we need to be in there clearly, and again, underscoring the importance of acute care partnering. So this is just a paper a white paper that we wrote, which was just a summary paper of the COPD patient 30-day hospital readmission. If you're like me, you try to read and keep up, and what's coming out on COPD is just overwhelming. I will tell you that no one knows exactly how much the reduction in readmissions, what target, whether it's 10%, 15%, but I would say it's important to know where you're starting from, and it's important to be in that chain of referral and to get pulmonary rehab in your order set, to get in front of your hospitalists and to make sure that they know your service line is there. It's very, very important. And the guidelines, all of these, the Cochrane Review, the ATS, ERS papers, they all talk about pulmonary rehab within the first 3 weeks to 4 weeks of discharge, as well as talking about early rehab, which is moving patients while they are hospitalized, and that is in bullet number 2. There's a considerable amount of information. This is a very dense document. It has a lot of really good information, so When I reviewed it, I just did it in sections, but you will want to get that. That was published in 2014. Professional certification, I wanted to share with you that it doesn't exist for pulmonary rehab yet. It does exist for cardiac rehab professionals through the AACVPR. They started that last year, and they actually are pushing that out to the states. The AARC, in fact, Shauna put together a really great program in March, had the Chronic Disease Educator course, which covers all the chronic diseases that we are treating. And the next one, I think, is coming up in September. You might want to check that out as well. AACVPR now has AARC and the COPD Foundation as strategic partners, and I think that's really a great mix and a lot of really good talent, so that all of us will be able to get the education and the support for our programs. Maintenance, I see there's a couple of questions. People are talking about reimbursed for maintenance. Maintenance is not a reimbursable product by Medicare. That is part of the statute as I understand it, and so patients self-pay for the services. I would encourage you to pose these questions that are listed on the slide to yourself, which is, what does it cost you? Because it does cost you. It costs you in the fact that your equipment is tied up and also your staff are tied up. And I'm thinking about alternatives to move it to the community. There are no standards for which how often do you need to get authorization or order referral from the physician to keep the patients there in maintenance, update medications. I know without question we have provided quality service to these patients. We do vitals when they come in, and we assess them during their exercise. And they can come up to twice a week. It's basically cheaper than a Subway meal deal. It's $6. I haven't raised it in a million years. But I don't want to price patients out of it. I really do think that as our business is growing, that we really have to look long and hard about having maintenance services within a hospital clinic that's here to provide rehab predominantly, and whether we can explore partners in the community and keep our patients engaged in long-term rehabilitation. Food for thought, what will your program look like this time next year? Will some of you be retiring? And if so, I'm hoping that you have a succession plan. Will you have more staff and provide more services, or will you be looking to get more space? So in summary, there are many different models for staffing and delivering services depending upon your resources. As you expand services and your volume grows, I think our models overall need to be more flexible, and flexible enough to meet the demands while maintaining the standards. All patients are not going to be able to come in groups and may not be able to come for the full course of program. So with that, I'd like to thank you. I appreciate everybody that has taken the time out of the day to join the call. Thank you so much.
Thank you very much,
Shauna?
Trina. Yep, I'm here. Thank you so much. That was really, really great. We don't have a whole lot of time for questions, but I do think that I can ask a couple. So one of the questions that we got was how, pardon me, I just lost it. How do you determine when the patient comes in and you're trying to schedule their sessions, what do you do with patients that say that they can only attend a few of the sessions and not the whole program?
Well, I think that's a great question. Sometimes on the phone, patients will say that, and there was actually one study, and I don't have the reference off the top of my head, but if you can go with the idea that if you can at least get them in for the first session, because keep in mind, that's a trial run for patients like us that have never been to our center. So they know how far to come, they know where to park, all the things that people get anxious about because they're not really sure that they're up to the physical requirements of getting there. And then we have to be best. We have to knock it out of the park. We have to basically be worth it for them to get here. And once you engage them and they see what it's like and what you provide, if you still cannot schedule them for the full gestalt of the classical, what I call the classical model of rehab 2 times a week for 8 to 12 weeks, then what I would put together is what I call a boot camp, which is you got to do breathing, you got to do inhaled meds, oxygen if it applies, They have to know exacerbation assessment, and they need to know how to exercise and implement that at home. So, and smoking cessation in those who need it. So that's what I mean when I say boot camp. Let me give you the basics, and then let me see if I can at least get you back in a few times to help you build the basics. Or if I really think you need the peer-to-peer, let me put you in a group for a month, and then let's reassess it. And sometimes just from that experience and the gains, those patients will want to continue.
Thank you so much. And you know, reading through the comments and the questions, there are several questions that I feel a little bit guilty that I'm not going to be able to ask. Trina, if I email you these questions, would you email a response back and then I can post this with the archive?
Yes, I would be happy to. And my slides do have my email, and I don't know how many people are on here. I know there was a lot slated, but I do my best to get back to people in a timely fashion in between seeing patients like all of you. But I welcome the opportunity to share, because I do think it is important for everybody to be able to provide rehab as community resources. And you know, the better we can run the business, the more time we have to actually help our patients. So I'd be happy to, Shauna.
Fantastic. So we'll post the archive of the video in the next week or two, and then as soon as I'm able to get the questions to Trina and she has a chance to respond, I'll post those to the archive as well. So again, Trina, thank you so much for joining us today. We appreciate your time.
Thanks for the opportunity.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.